Just a little bit of housekeeping before we proceed. Firstly, I neglected to introduce Danielle Walsh, who's with me as the co-chair. Thank you, Danielle. Secondly, please submit your questions using the SAGES app. At the end of the session, we'll have, if we have a few minutes, we'll have a panel up here. We'll invite all the speakers and go through some of those questions from the audience and online. Danielle will introduce the next speaker.
Welcome, everyone. I'm pleased to introduce our second speaker. It's Dr. Karen Horvath. She is professor of surgery and the program director at the University of Washington in Seattle. Her areas of clinical expertise are necrotizing pancreatitis and colorectal cancer, and she's been kind enough to speak on necrotizing pancreatitis today. Dr. Horvath.
Thank you very much. I'd like to thank SAGES for program committee for giving me the opportunity to present to you about MIS for pancreatic emergencies. And basically, I have no disclosures, that translates to necrotizing pancreatitis. So just an overview of my talk today. I'm going to talk to you just briefly about the reclassification of acute pancreatitis because I think it's important that we're all talking the same language, the evolution of timing for surgery that's occurred, and some MIS options for drainage. So the first thing is the Atlanta reclassification project. Over time, as we've used the 1993 Atlanta classification, there have been some acknowledgement that there have been some problems with this classification. For instance, what actually is a pancreatic abscess, and everything is called a pseudocyst, and everything is not a pseudocyst. And so because of this, there was an international consensus conference that took 5 years to basically reclassify the Atlanta classification. And this is what the revised classification looks like. So you can have a severe acute pancreatitis. You can either have interstitial edematous pancreatitis or necrotizing pancreas. You can see that the disease is then subdivided into the early phase, the first 4 weeks, and the later phase after 4 weeks. And we call collections different things at different times. The thing that I'm going to be focusing on mostly today is walled-off necrosis or infected walled-off necrosis. And you can see that pseudocysts are actually a very, very small percentage in actuality of these patients. So let's next talk about the evolution of timing for intervention. And basically, as we've gone forward in time, we've delayed intervening. And so from necrosectomy or total pancreatectomy in the first few days, in the mid-90s, 2 to 3 weeks, and now we're really waiting for 4 weeks. You can see in the graph of mortality versus time of surgical intervention, as we've delayed intervention, the mortality has decreased. And this is the reason why. So this is a CAT scan done at T-1 day, the day before the patient got sick, 4 days, 30 days, and 48 days. And you can see all of the edema and inflammation and how over time that really kind of condenses and you get a nice mature wall in that 48-day and 30-day CAT scan. And so and this is a panel about acute care intervention. Is there really any reason for early phase intervention in that first couple of weeks? And the answer is really no. And I think that one of the things that I think we have to be careful is this whole idea of just because we can doesn't necessarily mean we should. And I encourage you to try to avoid ERCPs, pancreatic duct stents, percutaneous drains, and transgastric procedures in this early phase because unless the patient is already infected, you can actually cause an iatrogenic infection. Intervention for sterile necrosis. I think, and we don't have a lot of time to talk about the controversies here today, but this is, I think, a picture is worth 1,000 words. And if you look at this patient, 30 days and 6 months, this is a patient that did not have any intervention at all for their acute necrotic sterile collection. So basically, it just resolved with supportive management. So when we do intervene, what are the optimal methods? I think that this is an area still where there's not a lot of very strong evidence. except we do have really good evidence for the step-up approach with the Panther phase 3 randomized trial from the Dutch group. And basically, what they did was they randomized their patients to a step-up approach versus the open necrosectomy, and really found a significant reduction in the composite endpoint of death and major complications, long-term complications, and also significant health cost savings. And so the step-up approach, I like to think of is, I call it the 3 Ds of the step-up. We delay, we talked about that. We drain, there's the percutaneous drainage, and I'm going to focus on that a little bit. And then when a percutaneous drain doesn't work, then we go to debridement, and there are many, many ways that we can debride these patients. So percutaneous catheter drainage. Again, a picture is worth 1,000 words. These are 4 patients who were successful only with percutaneous catheter drainage. So we don't know how to predict who those patients are going to be, but we do know that it can occur. And I think that that understanding is also backed up by some really good data. 2 very large systematic reviews, a prospective study, and a randomized controlled trial, each showing that yes, there are a subpopulation of patients where this is successful. But when that fails, then the patient does still need to be effectively drained. And again, I'll talk about a little bit about the VARD approach. The VARD approach, first we place the percutaneous drain. We make a small incision in the mid-axillary line, enter into the collection, do some debridement, and then place a laparoscope in and debride the rest under direct visualization. I'm not going to show a video today for time limitations, but there is one on YouTube for you to see. And so I think that some of the advantages of a VARD procedure, it's very effective. 80% of patients only need 1 procedure, and then 20% will be taken care of with 2. Very simple to perform. It's very low tech. We don't need fluoro. We don't need endoscopic ultrasound. Very low costs. And I think one of the nice things is that a VARD can be done in a resource-poor setting where we don't have a lot of high-tech things that are available. So what about some transgastric approaches, both drainage and necrosectomy? I think we've made some really significant advances in this area over the last decade. This can be done, either of these can be done, either transgastric or transduodenal. They should not be performed until the necrosis is organized, until the wall is matured. One of the things that's really advanced this field forward substantially are the new 15mm Axios stents, and I've shown those to you right there. So here's a patient that's being drained with the pigtail stents transduodenally, and here's a patient with the Axios stent being debrided transgastrically with the endoscope. I think there is a lot of expertise and technology required for these patients. It's really excellent for head and neck collections, but we definitely need more research. So in conclusion, I think it's very important that we're all talking the same language, both in clinical and research communications, and no longer calling everything a pseudocyst. Delay necrosectomy up to after about 30 days. Wait and step up, I think, is definitely the new standard. And when drains fail, there are lots of different options. I think that these patients, very low prevalence disease, and really represent personalized medicine and need a customized approach. And so I really think these patients belong on the surgical service, whether or not they're actually going to need surgery. It's my personal feeling. And I think at this point in tertiary centers. Thank you very much.